amyloidosis is a relatively rare disease, and there were not many dedicated presentations for amyloidosis. However, we did see data regarding the treatment of patients with daratumumab monotherapy, especially patients with stage 3B disease. We also saw some very interesting data regarding other combinations such as daratumumab with ixazomib, lenalidomide, dexamethasone, and also we did see some real-world data showing that there is an improvement with the use of novel therapies such as daratumumab. What is also interesting was the presentation regarding the use of birtamimab. There was a post-hoc analysis from the VITAL study showing that in patients with revised Mayo stage 2012 stage 4 disease, there was a substantial benefit in terms of overall survival at 9 months after suspension. So I think all these are very important, showing that the field is moving forward. So in this ASH meeting, we had a presentation regarding the use of daratumumab monotherapy in patients with newly diagnosed stage 3B disease. This is a very high-risk group. These patients have a very poor outcome. However, with the primary endpoint of overall survival at 6 months, we observed that in 31 patients who were treated prospectively in this study, and which has almost completed accrual, the overall survival at 6 months was above 60%, and actually the median overall survival is almost 12 months, indicating substantial improvement in the management of these patients. Of course, we need to do a lot more. We also presented data regarding the prognostic significance of circulating plasma cells in patients with amyloidosis. In 57% of these patients, we do detect circulating plasma cells. Of course, this was not associated with the overall outcome of the patients, but was associated, for example, with the probability of deep hematologic response at 3 months, which is a critical time point in which we make decisions for the change of therapy. And also there was some difference in the probability to achieve MRD negativity after treatment among patients with or without circulating plasma cells. I think, first of all, it is very important that we finally have an approved regimen for patients with AL amyloidosis. This regimen is associated with substantial improvement in terms of hematologic responses, complete hematologic responses, and organ responses in patients with cardiac or renal involvement. I think that in the long term, this will improve the outcomes of our patients and their survival, and I think also impacts the treatment strategy in many centers. For example, I think it will reduce the need for autologous stem cell transplantation as a consolidation strategy in many of these patients. This is a very important issue. I think the most important barrier is reimbursement. So although it is an approved therapy in many countries, reimbursement still is problematic. And I think it is very important that patients with AL amyloidosis will get access to daratumumab in first-line treatment. This is a therapy that has shown, that has proven its efficacy and is associated with substantial benefit for all patient subgroups who have stage 1, 2, or 3A disease. I have to note here that patients with stage 3B disease were excluded from the Andromeda study. However, the data that we presented regarding the use of daratumumab in stage 3B show that this drug could be safely given in patients with advanced amyloidosis. We are now in the position to have prospective randomized studies exploring the use of antifibril agents as part of the first-line therapy in patients with cardiac amyloidosis. This includes the AFFIRM study, which explores the use of birtamimab, in which, as I told you, Dr. Gersh presented the post-hoc analysis showing benefit for stage 4 disease. and also the Kaelum compound, which is also another monoclonal antibody targeting the amyloid fibrils, which is explored in patients with stage 3A disease and also in patients with stage 3B disease, and I think this is very, very important. It's a difficult population to enroll in clinical studies. What is also important is that we have to look around us and see the advances we have in multiple myeloma. It is very important. What we see is an explosion of novel immunotherapies, mostly T-cell directed therapies with multiple targets, BCMA, MCR, H5D, GPRC5D, and this will eventually come to the field of amyloidosis, and I'm pretty sure that will help many of our patients. I think that one of the critical issues will be the management of patients who fail to daratumumab therapy or relapse after daratumumab therapy. We also had a poster describing the outcomes of these patients. Patients showed that you have to have an effective therapy with a different mechanism of action in order to salvage these patients. I think it's very important to have new BCL2 inhibitors that can be used in patients with T11-14 translocation, which is about 50% of patients with amyloidosis. So there were some data. There was a presentation as a poster for a compound from Zentalis, in which we explore in phase 1 study. It's a new BCL2 inhibitor. Venetoclax is also a drug that is available for other indications and can be used in patients with amyloidosis. Belantamab mafodotin is also a drug that we also presented and is explored in a phase 2 study from the European Myeloma Network, which shows also very promising results, however, with the issue of ocular toxicity. So we will wait. I think very soon we will also have some data for the use of T-cell directed therapies in this population. Overall, I would say that the data are promising and we should have hope, and our patients have hope that new therapies are coming and we will be able to overcome many of the obstacles that we have today. Well, our patients will have more options. I strongly believe that the best therapy should be used first. However, there will still be some patients who will fail this therapy, and we have to be prepared to treat them in case of failure, and having more and more options is critical. I don't think that any drug should be just thrown away because of lack of impressive efficacy. Every drug has a place. Every drug that shows some signal, some patients may benefit from this. So it's good to have many options. We should not restrict our options to a couple of drugs.